Professor Jennifer Leaning, welcome. Members of the prevention community in public health, prevention of atrocity, members of GAAMAC and partners, I'm very happy to hold here the second conversation about, or the second episode about what can we learn from COVID-19 for atrocity prevention strategy to become more efficient. So Jennifer, last time we have listened to you about primary prevention, secondary prevention, third, all these different dimensions of prevention. I also want to say that I'm happy that we received some questions after our interview, which was broadly followed by many people. We received a lot of interested reactions and two very specific questions stemming from Ghana and from Israel. And I thank our colleagues who sent us this excellent question. So last time we talked about the different stages of prevention, and we also began talking about early warning signal. For today, I would like to recall something that you know so well, Professor Leaning. It's that in the field of the prevention of atrocity, we state that prevention of atrocity shall be permanent because we need to act very early, notably, for example, at the premises of hate speech, incitement. In other words, with everything that triggers problems around identity-based issues and the management of diversity. The question we received from Ghana that I tried to formulate like this is that violence is a multidimensional phenomenon that includes direct violence, but also cultural violence, structural violence. And the commission of atrocities is indeed one of the last stages of violence. The question that we received from Israel recalls us that during COVID-19, we are seeing important trends emerging, but they are not new. Somehow it's related to identity, to incitement against specific groups, and threats against a constructive combination of democracy, the exercise of democracy, and the management of this diversity of minorities, etc. So, Professor Leaning, if I can share with you and enter with you in the first question, in relation with this identity-based issues and management of diversity, what can we learn from the impact of COVID-19, and I would say also the work in COVID-19, as we are already in secondary prevention, the illness is there, regarding this three dimension of violence that shall be prevented. From a public health point of view, are these three dimensions, direct, cultural, structural, relevant, meaningful to you in public prevention? And are public prevention workers taking them into account? And how? What are the measures, for example, taken to face them? And what could we learn from that for our atrocity prevention strategy? So Jennifer Leaning, you have the floor. Thank you.
Well, thank you, Mo. And thank you to the GAAMAC headquarters for organizing this second video. And it is a pleasure and an honor to have a chance to interact with you on these serious questions. I would say that we are now in COVID-19 in a definite deep stage of secondary prevention. The epidemic is full blown, it's out there, it's affecting millions of people, and it has sadly killed hundreds of thousands of people in all parts of the world. These dimensions of threat and violence, that is direct, cultural, and structural, relate very well to the dimensions of how one understands the spread of an epidemic and the efforts to contain it. I would say that in secondary prevention for public health, you begin to see the sinews of public health action, its capacity to interact very strongly with society, its the necessary close collaboration between public health authorities and the authorities of the state at all levels becomes crucial. And issues of human rights and rule of law become paramount, in addition to efforts to contain and deal with the disease. So in secondary prevention, and we're talking about these three dimensions, and in terms of the direct issues, you have the spread of the disease and its morbidity and mortality effects. This is what happens when you begin to have hate speech surface, let alone hate action. It causes real harm and it spreads. The cultural dimensions for containment of a pandemic include responding to the very significant fear that this disease creates in populations across the world, and the tendencies of populations to react to this fear with some stigmatization of suspect, vulnerable minority populations. Now, in this particular epidemic, it strikes everybody, but it does strike certain segments of society more than others. It has not resulted in massive stigmatization of minority populations or those that are discriminated against or those we would consider targets of hate speech or hate action in the context of atrocity. But there are some parallels. So for instance, it requires very strong and positive leadership to bind people together rather than have them succumb to fear, to the potential of stigma, to blaming others for the disease spread. And this is then an issue of the highest authority of the land working with public health expertise in creating the right messages and space for people to calm down, for public health to do its work, and for the authorities of the state at the provincial and district levels, for the authorities of the state to move into their more detailed ways of interacting with the populace. So for instance, in COVID-19 in the United States, we have a very difficult national leader, but the governors of the states are really proving to be fundamental leaders of the response. And in many ways, not all, it's completely appropriate because public health authorities can move through the states with the governor's permission and the mayors behind them to create enormous safety zones and support for medical workers and health workers and protection of those who have to stay in essential workplaces but are therefore disproportionately exposed to the spread of the virus. So it's a cooperation, command, and control set of issues. The problem that becomes structural, and this is the third dimension of what you outlined, Mo, is that there are segments of the population that are more vulnerable to this disease or more vulnerable to stress or attack, if we're thinking about atrocity response. And the authorities have to work within a respected and robust rule of law. That is, they act on the authority that has previously been granted them before the emergency. And the extent to which they have to impose new containment strictures, new methods of controlling populations, whether this is in public health or in atrocity prevention, they have to do it within ethical guidelines in public health and principles that have been previously agreed upon. So there are strong imperatives to speak frequently to the population, to make it clear that everyone is at risk and everyone is going to be protected as necessary, and that the vulnerable groups, this is in the disease parameter now, the vulnerable groups include those, as we are understanding COVID-19, to be those without social safety nets, those whose jobs do not provide health insurance, those who rely on a daily wage because of their daily labor, and there is no network of support if they cannot go to work. Those who are weakened by pre-existing chronic conditions. The elderly are turning out to be very susceptible. But that is the way in which we think about atrocity. We consider who is at risk and how do we intervene to support those at risk. So I think there are considerable parallels between prevention in public health or secondary prevention and what's necessary for the outbreak of hate speech containment.
Yeah, thank you, Jennifer. I mean, I find it really amazing and so interesting to see that actually public health prevention is there since decades, right? And it functions, it has procedures, protocols, it has institutions, it even has an international organization called World Health Organization. So there are decades of experience that basically, especially in setting up an architecture, in understanding indicators also and ways to proceed that can be useful for us in prevention of atrocity. So it's evident, again, it gives us again a kind of proof that it's useful to make this kind of comparison. Now, we are indeed talking, as you recalled me before we began the interview, acting now, basically already too late, right? We are acting within the pandemic. But when we take these three elements and we transpose them really in the moment of prevention, which is before the events, right? Prevention shall really happen before, then it happens in a secondary level, as you were saying, secondary stage of prevention, to protect other groups, to protect it to be disseminated, etc. So basically what I'm hearing from you, if we transpose as far as we can, is that we need rule of law, we need institutions which are really working for the common good. We need clear rules of the game for the society, to behave and to stand together. We need also political decisions to be taken. And I think it's quite troubling to see that in numerous countries, there are no reserves for masks or for public health system has been dismantled in certain countries, etc. So we need the state to structurally ensure that each of the citizens is covered, basically, right, in its global needs. And as you said, we need also a kind of very intensive cooperation between the scientifics, the medical doctors, but in atrocity prevention can be other milieux also, and the political authorities. So that based on fact, these political authorities can basically speak and suggest policies that are not only good for the common good, respecting rule of law and human rights, but also based on facts, correct? And this needs to continue when the pandemic is there. This is obvious, right? So basically, this kind of elements and way to approach are very, I think, very useful in all stages of prevention, right? And I think it leads us actually quite naturally to the second question that stems also from a colleague in Israel. And basically the way to translate this question could be the following, that effective preventions requires effective and constructive cooperation among governments and societies, nota bene, even more in this globalized world. And in particular, it requires clear rules regarding respect to human rights and rule of law. You just touched upon it. But in this time of COVID, and I'm very interesting to hear about your field experiences, we witness very worrisome tendencies, as you know better than I do, some emergence of dictatorial and autocratic behaviors, which are not new from COVID-19, but have a stronger impact, I would say, in this very vulnerable moment. Explicit rejection of multilateral cooperation that we are witnessing since years, but now have a stronger impact also. Expression of absolute denial of reality by politicians, and new massive trends in violation of human rights. Let's look at the prisons, for example, lack of access to justice, etc., including also in certain countries, decisions to take back indigenous land for production under the so-called need to now overcome the economic crisis, efforts to undo peace agreements in several countries, and you name it. So violation of the rights of migrants and or international agreements about refugees and international humanitarian aid, to name only these ones, right? So my question to you would be, Professor Leaning, back to this dialogue between public health and prevention of atrocity. So in prevention of atrocity, you are in public health, so you are very familiar with this kind of very adverse situations. And I can recall when you came back from certain very difficult countries. So these are man-made situations. We have to recall that. So from a strategy point of view for public health, how do you navigate in this kind of very, very adverse political context where authorities are not basically going through the right path, if we can say so? How do you navigate in this very adverse context? And what are the elementary criteria that you would have to act and to be able to have an impact in prevention at whatever stage you are in? And in turn, what can we learn from this for the prevention of atrocity to become more efficient?
Well, there are two levels at which I would respond here. One is what the measures of secondary prevention can tell us in relationship to the prevention of outbreaks of hate speech. And the second one is the extent to which a really good public health response depends upon international cooperation and how that is relevant to prevention or secondary prevention of hate speech in one part of the world. So the first one is that in secondary prevention, the government asks the public health authorities, and the public health authorities ask the government for permission to do this, which is to begin to identify contacts of those who are sick and to begin to trace those contacts and then to move farther out to get a sense of how far the disease has spread. Contact tracing is an invasion of privacy. So there are rules about anonymity, about getting permission from the person who is ill, of seeking him or her to provide full disclosure, not to lie about whom they may have seen, to get them to think carefully about this. And then you proceed out in a very, very dispersed but invasive mode. Now, it can be done with volunteers. Here in the state of Massachusetts, we have undergraduate students from the universities who are not in such a vulnerable age group, B, don't have much to do because the schools are really closing down, and 3, really want to help. So they are now involved in contact tracing on the telephone, going out and at a distance knocking on doors, and essentially trying to figure out how many people might be affected in the state of Massachusetts from one index case. This is going to be essential for us to understand how to contain the epidemic once we begin to lift quarantine. Now, another big issue that is in secondary prevention is that we may need to keep excluding groups from contact with others because they remain infected. And that requires understanding who is infected and who isn't, which is another question. But the parallels to secondary prevention in atrocity crimes are that at a certain point, the state authorities at various levels are going to have to be intrusive in figuring out who is actually causing this harm and who needs to be protected from it. And the general society has to trust that they are operating on these maneuvers within an established rule of law and respect for human rights. So that would mean complete anonymity of who is talking to the authorities, complete protection of those who may be at risk, measures to provide safety for those who have to be moved into another setting. This is in the context of a disease, but also an atrocity. And so prior to secondary prevention, which gets to be a little bit in public health and I think in atrocity prevention, a little bit intrusive, prior to that, there have to be compacts between government and citizens at all levels about what we agree will be necessary in a state of emergency, whether it's a disease or atrocity outbreak. So again, it comes back to preparation. Now, if we're talking about this issue of international cooperation between governments, that we have seen that both work and break down in the COVID-19 case dramatically. International supply chains are being disrupted, and then entrepreneurs send planes to China and bring back, PPE. We have certain governments insisting that WHO misled them or didn't act robustly enough. We've got one government that is, taking funding away from WHO, a significant share of its funding, in defiance of pleas from the rest of the international community. We have border closings in Europe as well as in the Americas, and therefore people trapped on either side. And the public health community has been urgently trying to keep in a cooperative mode across countries and with WHO so that the science of understanding this and the preventive measures and the treatment measures can be evolved collectively. And the flip side of COVID-19 in terms of how the governments have behaved is that the public health community has become much stronger in their interactions, and they've speeded up so many investigations. Now, in atrocities, the sort of network and national architecture that R2P is proposing, that GAAMAC is working within, the documents and declarations and guidance from the UN history of dealing with atrocity crimes, these provide the robust structure for international cooperation. And what we need to be strengthening is the public health community, which to me would be those who are on the front lines of atrocity prevention in the national architecture. They need to be linked country to country so that they form a community of assessment, response, and encouragement, and if necessary, reproof for nation states that are becoming rogue.
Jennifer, I'm listening to you, and I can only imagine that some of our viewers are thinking, wonderful, this is the way to go, cooperation, information, sharing. But actually, as we know, we are living in a world where there are heavy attacks against multilateralism, and there are in certain countries authoritarian regimes coming up. So in this very adverse situation, what I'm hearing from you is that might be a little bit provocative, and I would like to hear you on that. Basically, if these are the conditions under which prevention can work, then it's almost impossible in prevention of atrocity to realize prevention, because when really hate speech are already ongoing at such a level, like we have COVID now, it means that rule of law, human rights, institutions have already lost sight of the common good. Is it an indirect way to tell us, Jennifer, that unless prevention of atrocity is a permanent architecture that is established in, I would say, times where it's possible to discuss about all these issues without extreme tensions, then it will be very difficult in the time of the pandemic, and it takes different forms. Speaking of hate speech, incitement, discrimination, it can go further than that. So basically what you are saying is that we cannot practice prevention with the whole impact needed if we don't have already, because we have prepared it, a system that is already in place of cooperation, clear understanding and joint understanding, shared understanding of what needs to be done, who needs to take decision, at what speed, and what will be the relation between the scientists and the governments, etc. Is it what you are telling us?
Yes. Thank you for putting it that succinctly. There really are very few mechanisms for dealing with the outbreak of atrocity in a particular country, because it's usually nationally based. It may spread, but it usually begins locally, just as human rights begin locally. Atrocity will begin locally and spread. It can emanate first from the leadership, which is possibly more deadly, but it's national. And the international community has very, very rough measures, sort of rough pod measures to try to stop that. They can do sanctions. They can send, gunboats up the river. They can stop the banking system from working. They can declaim in the UN in all sorts of ways. And if all of these restrictive measures bring absolutely no change, then they actually have to think about whether they're going to intervene in terms of military force. And there's such a high threshold against doing so, particularly, well, I would say throughout since 1945, there's a high threshold against intervening. At a regional level, perhaps some bordering states feel they can go in with more impunity. But in general, that is a very rough way and brutal way, and in general, ineffective way to deal with atrocity within a nation state. Of course, the nation state will have to acquiesce. There will be a quietness back in the countryside. Something will change, but then you have a smoldering invasion and UN peacekeepers, and that's several decades of tension and instability. So the idea of creating a response network within the national architecture is absolutely essential. If we look at how atrocities begin and how they're ended, they must be dealt with at the level of very strong media. Media are essential. Aspects of government, even in the opposition parties, if there is a dominant party that is actually very nationalistic and increasingly deadly towards minorities or stigmatized populations, there's got to be international ties with elites and community leaders from all around the world, but best case, if it includes people from the same region. In other words, invite a delegation in to have a big meeting in a big central hall in the national capital, and the outsiders who are semi-outsiders because they may well know the culture and language of their adjacent neighbors, they can basically provide a different narrative, a different perspective. They clearly have to be, morally charismatic in order to be able to have an influence. But the larger community can come in at the invitation of the national architecture, and the national architecture can call for more allies from within their country, people who they know are on their side but have not been particularly active, and say, can you help us in this, upcountry region where this is happening? Be in touch with us about how we're going to handle X or Y. They will do this at risk to themselves. I mean, that is the flip side about being part of the national architecture for atrocity prevention. They can be leaders in good times, and they must be, because they've got to create the preventive measures and the preventive climate of opinion. But they're going to have to be leaders as well in difficult times and imaginative in how they can calm their society.
So I think it has been very important to listen to you again today. So Jennifer, I take from this conversation several elements. One is the importance to address all the different dimensions of prevention, namely the cultural one, the direct one, and also the structural one. The second element is preparedness. It's absolutely central and key. The third element is cooperation is key, but the real effort needs to begin very, very, very early on in non-illness time or in non-troubled time by agreeing on what the main elements have to be of attention, of worries, of in each society, in its cultural context, historical context, minority, majority, etc. And and this kind of agreement need to be somehow already there to be able really to prevent. In other words, you have told us that if we have made the mistake to think that prevention is when we are talking about a military intervention in times of crisis, and that's the Security Council decisions, for example, this is much too late. This is not prevention at this stage anymore. This is intervention. So prevention begins much more early and generates long-term commitments, long-term actions. And in the field of prevention of atrocities, basically, it's a strengthening and a protection of democratic institutions and basically these values of what we call civilization, right? Which has different forms and different contexts. So I think it's, again, fascinating. And I suggest that we continue the conversation for a third interview next time, where we could explore together, among other issues. Certainly we will receive questions and observation, but what can we do to continue thinking, like you have correctly pointed out, from a bottom-up approach, namely from the national level to the international level. What are the means and ways in which public health prevention has been organized until now and could teach us also elements, lessons learned, success and failures from which we could learn. I want to thank you again so deeply, Jennifer. It's always a pleasure to talk with you, and it's in particular very, very enriching. Thank you very much. For our viewers, if you want to ask us questions, make commentaries, you are more than welcome. Write us simply a note to our website that will appear on the screen, and we hope to see you soon. Goodbye. Thank you very much.
Bye. Thank you.